Okay, I think we'll get started. Hi, everyone. Thank you so much for joining us today for our trainee research presentation, Hormonal Contraceptive Insights from Across the Field. My name is Laura Growelsons, and I'm subbing in for Lisa Galea today. And I'd like to just start off with a land acknowledgement. We recognize that we live, work, play, and participate in community on the unceded, ceded, and traditional territories of the 630 First Nations, each of which possess their own unique traditions and history here on this land that we now refer to as Canada. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action and the United Nations Declaration on the Rights of Indigenous Peoples. In all of our work, we are committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I am joining you from Toronto, which is covered by the Toronto Purchase Treaty Number 13 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. Many of our members live in Vancouver, which is part of the unceded homelands of the Coast Salish peoples and the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. Thank you so much for joining us, everyone. Today, we're here to talk about hormonal contraception, which are often treated as routine, everyday medicine, but they shape some of the most intimate parts of people's lives. Decisions about birth control can affect health, identity, relationships, autonomy, and well-being over time. Even though so many people rely on these medications, we still have big gaps in our understanding. We're still learning how they affect the brain and mood. We are still learning why some people have positive experiences and others do not. And we're still trying to understand how access is shaped by systems like education, healthcare, and policy. And we're still working to make sure that people have real options based on informed choice, not just availability or circumstance. This is why research and conversations like this matter. They help us move from assumptions to evidence, from stigma to clarity, and from one size fits all to care that actually reflects real experiences. So thank you to our wonderful trainees for contributing to this important progress. And thank you to you all for being part of this conversation today. Just a few housekeeping notes. We will be having 10 minutes for each presentation. And right after that presentation, we'll have 5 minutes for questions. I think we're probably ready to get started. So for our first speaker, we have Tendo Babirye.
Okay, I'm gonna share my screen. Can you see my screen?
Yep. Yes, that works great.
Okay, perfect. Thank you. So good afternoon, everyone. My name is Tendo Babirye, and I will be presenting my research findings from a scoping review that examines how incarcerated women within Canadian correctional facilities experience access to hormonal contraception. So the outline highlights the key sections we will cover. So this includes the background, a little bit more about the research, key identified barriers, and proposed interventions. So just to give you a little bit more background, so hormonal contraceptives contain estrogen and progestin and are widely regarded as safe for pregnancy prevention. They also come in various forms such as oral pills, patches, vaginal rings, and intrauterine devices. Beyond contraceptive efficacy, hormonal contraception can support the management of endometriosis, PCOS, and heavy menstrual bleeding. Given the wide range of benefits, it is crucial that contraceptive users are adequately supported to choose a method aligning with their preferences, their needs, and their reproductive health goals. However, this can be difficult to achieve within a correctional setting. So while women represent a rapidly growing population within Canadian provincial and federal correctional facilities, with most being of a reproductive age, access to reproductive health services such as contraception remains inconsistent and deprioritized. The United Nations Mandela Rules and Bangkok Rules outline standards for the treatment of incarcerated individuals and emphasizes gender-specific healthcare, including reproductive care for women. Although drug formularies may indicate that hormonal contraceptives are available, limited quantitative data and inconsistent documentation suggest that availability doesn't necessarily signify access within the correctional environment. So through a search of databases, particularly PubMed, 7 publications of which were published between 2016 and 2025 and conducted within Canada met inclusion criteria, and thus were included in the scoping review. So given this topic is generally under-researched, the scoping review aimed to synthesize available literature to better understand incarcerated women's experiences with hormonal contraception and identify barriers to accessing it, which could potentially inform interventions that can improve its access. So the review identified 5 main barriers to contraceptive access in these settings, which included structural and institutional barriers, mistrust in correctional reproductive health care, competing health needs, limited reproductive health knowledge, and challenges with continuity of care. Each barrier is further broken down into subthemes, which are shown in the figures 1 to 5 in the following slides, along with supporting quotations from women with lived experience in Canadian correctional facilities. So structural and institutional barriers had a strong influence on incarcerated women's access to hormonal contraception. Quantitative data supports the quotations presented in Figure 1, where one study found that among the 14 women who reported the use of hormonal contraception prior to entering custody, only 5 women had continued while incarcerated. Thus, within a correctional framework, institutional challenges may compromise and limit reproductive autonomy, influencing access to contraception. This is evident in requests for reproductive care and admission processes, where research found that when submitting a health request to correctional officers, many women experience gatekeeping of services, violations of confidentiality, prolonged delays in processing requests, or the overall denial of care. So these procedural gaps actually reflect a broader absence of policy affirming access to hormonal contraception and the protection of incarcerated women's reproductive rights. One study found that none of the 14 jurisdictions contacted had maintained an up-to-date policy supporting access to hormonal contraception. This could explain the limited count of contraceptives provided by the jurisdictions. Thus, while both federal and provincial laws recognize inmates' rights to accessing health services, an absence in proactive contraceptive policy highlights potential barriers to its access. So another barrier identified would be mistrust in correctional reproductive health care, reflected in concerns about mistreatment, breaches in confidentiality, coercion, and discriminatory practices. A number of incarcerated women reported feeling judged or dismissed when requesting health care, particularly by correctional officers. As a result, asking for family planning services, such as hormonal contraception, can create significant discomfort in this population. So the mistrust also extended to healthcare professionals. So many participants described having experienced reproductive coercion, where contraception use was either completely imposed on them or denied because of the institutional restrictions on sexual activity. So the correctional environment thus deepens mistrust and reinforces inaccessibility to hormonal contraception. A key barrier would be competing health needs, as incarcerated women often have complex health histories of which intersect with their reproductive health outcomes. In these studies, the women emphasize the significance of having their socioeconomic and general health needs met prior to being prepared to plan for or prevent pregnancy. So thus, while numerous women experiencing incarceration described having to prioritize specific needs over others, this is due to the scarcity of resources and limited access to healthcare services in correctional settings. Given this, reproductive healthcare, including access to contraception, is often overlooked to prioritize other health needs, such as mental health and addiction services. These needs can significantly be more pressing due to overall carceral environment, which includes restrictive practices and systemic challenges of which can exacerbate existing mental health and substance use concerns. Another barrier identified in the research was limited reproductive health knowledge. For example, one study found that 44% of participants desired more information about contraception and its access during incarceration. So knowledge gaps pose barriers to reproductive care, as a lack of information is often misplaced and replaced with misinformation, perpetuating negative attitudes and just overall negative perceptions about birth control. So this was evident in another study where focus groups shared misconceptions about various contraceptive methods. And not only this, but incarcerated women expressed numerous concerns about symptoms and side effects, including long-term considerations such as cancer risk and impacts on future fertility. So additionally, the knowledge gaps extend beyond understanding contraception itself, but to uncertainty about where to access it within these facilities. So many women were unaware they could even begin contraception in custody. And these gaps in knowledge underscore the need for educational programs and for healthcare professionals to support informed reproductive choices that promote and respect patients' autonomy. 4 studies identified that a key barrier incarcerated women face in accessing birth control includes challenges with continuity of care. A cross-sectional survey at the Vanier Center for Women found that among the 58 women who did not intend to become pregnant following release, 38% were unsure and did not intend to use contraception. So although this reflects a lack of intention, it does not signify disinterest. Numerous women described having a desire to initiate hormonal contraception. However, lack of follow-up and poor coordination between correctional and community health care discouraged their initiation. Other post-release barriers, including not receiving a supply of contraception, lacking identification, and a high cost of methods such as hormonal IUDs, ultimately restricted its access. So given that incarcerated women value consistent contraception access, it is imperative that they are supported in not only initiating and maintaining it while in custody, but also continuing it upon release. So across multiple studies, participants shared insights that could actually inform interventions and improve the quality of reproductive care received in these correctional settings. So for example, to address competing health needs, incarcerated women emphasize that having more time with healthcare providers would help ensure that they can properly discuss their reproductive needs along with their other emergent health concerns. Women also proposed several strategies to address the knowledge gap surrounding contraception use and its access. They expressed interest in receiving clear information on the importance of contraception, who can use it, the available methods, and how to access it while they're in custody. Participants suggested multiple ways this information could be delivered, included the creative displays, so that would be infographics and posters, written material that is simple and clear, plain language, educational programs, or group sessions that are led by public health professionals that are trained to communicate with this population. These approaches are feasible, low cost, and low intensity, and have shown effectiveness in improving reproductive health outcomes in correctional environments, especially when women in custody are actively involved in the design, delivery, and evaluation of the interventions. So, ultimately, this research identified 5 barriers to accessing contraception in correctional settings. These findings emphasize that promoting incarcerated women's reproductive rights and their autonomy requires meaningful access to family planning services. Given the contraceptive and the non-contraceptive benefits of birth control, accessing it can be beneficial to women across all environments. This includes the community and the carceral context. That being said, incarcerated women should be informed about their rights to reproductive health care, and proactive policies and programming should be implemented to foster a correctional environment that promotes their access to contraception. These barriers identified in the review are interconnected, reflecting intersecting oppressions that are exacerbated within correctional settings. These barriers contribute to significant unmet contraceptive need and demonstrate how incarceration can disrupt reproductive justice by limiting autonomy and restricting access. So addressing structural, cultural, and operational barriers in correctional systems is imperative for improving women's access to contraception when in custody. And next steps should focus on improving correctional culture and reforming practices to ensure reproductive justice by engaging incarcerated women or individuals with lived incarceration experience in developing interventions that promote their access to hormonal contraception. Thank you for listening to my presentation. Okay.
Thank you so much, Tendo, for that really great talk. And it was wonderful to see that such rich qualitative data and such an eye-opening talk on access to hormonal contraception, especially within correctional settings.
Mhm.
We still have about a little over a minute for questions. So if you have a question, please feel free to post it in the chat and I can read it out, or feel free to raise your hand and I can call upon you and you can unmute and say your question. Go ahead, Katie.
Hi there. Hi Tendo. I really enjoyed your presentation. You offered a lot of really insightful points about reproductive health in the correctional environment. During your presentation, you identified 5 crucial barriers to contraceptive access. Given the limited resources in correctional systems, if you had to address one barrier first, which would you prioritize, and why do you think that would be the most impactful starting point?
Okay, well, I'm really glad that you enjoyed the presentation, and that's a really good question. So, obviously, I identified 5 barriers, and while they all deserve equal attention because they are mutually reinforcing, I would say I would draw more attention towards institutional and structural barriers just because this really reflects in the correctional environment and the correctional culture. And it is imperative to foster a culture and environment where the women who are incarcerated feel they're secure enough to ask for reproductive care services and ask for the family planning services. And it's evident that structural institutional barriers are a starting point which impede their access. And outside of my personal perspective and opinion, the data supports this. So while the other barriers had 3 to 4 sources that supported it out of the 7 that were retained from the studies, the structural and institutional barriers had 6 studies that supported that as a key barrier to receiving contraception and accessing it. So, yeah.
Thank you so much. I also had a follow-up question if we had any more time.
Okay.
So one point that stood out to me was the idea of competing health needs. And since this is a barrier that many people face in the community as well.
Mhm.
In a correctional setting where, autonomy and access are more limited, how might this issue become an even greater challenge?
Okay. Thanks. That's a really good question. Thank you. So, as you mentioned, autonomy. So in correctional settings, overall general autonomy is usually restricted, and there's practices that are meant to do so, even though that the correctional objective is also rehabilitation. So it can be challenging to balance that autonomy of restricting autonomy with promoting reproductive autonomy, right? So having that competing demands in correctional settings can be really challenging because they're exacerbated within these settings. So there's practices such as segregation that can exacerbate mental health concerns. And mental health is a huge topic that a lot of incarcerated women face and deal with even prior to being incarcerated. So that can be exacerbated in these settings and thus become more of a priority to address in a setting that is punitive and in a setting that can exacerbate those conditions. So that could easily get reproductive health put to the back burner. But that's a really good question. Thank you.
Thank you so much.
Thank you so much. And yes, great questions. Just for time, we're going to move on to the next talk, and then we can always circle back and have a more general question period if time does allow. So our next speaker, we have Alison Randell. I'll hand it over to you, Alison.
Okay, thank you, Laura. Let me just make sure I can share my screen. Okay, can you all see that?
Yes, that looks great.
Okay, perfect, thanks. All right, so my name is Alison Randell, and I'm a second-year master's student at Brock University. And today I'm going to be talking about my project titled Levonorgestrel Reduces Sex Differences in Tests of Anxiety-like Behavior in Long Evans Rats. So levonorgestrel is a synthetic progestin, which is a steroid that produces similar effects to the hormone progesterone. So this is an ingredient that is used in a variety of contraceptives, including the combination pill, the hormonal IUD, and in emergency contraceptives or the morning after pill. So cohort studies in humans have found that using progestin-only contraceptives can increase the risk of developing mood disorders such as depression and anxiety, and this risk is increased when that use is during adolescence. Despite this, few preclinical studies have looked into the effects of LNG alone on affective behavior, and the few that do have found very mixed results. However, the methodology of these few studies have been variable, where they all use very high doses, are mostly done in adult rodents, and only include female subjects. So that kind of leads to my research question, which was, how does chronic LNG use during adolescence affect anxiety-like behavior? So I had 48 rats in my study. So I had 24 females and 24 males, which were split into two treatment groups, one control group and one that received LNG. And so this is my experimental timeline. So they started receiving daily injections of their treatment in mid-adolescence, so right after pubertal onset. And then during late adolescence, they underwent a series of behavioral tests to measure their anxiety-like behavior. So the first test is called the elevated plus maze, where they're placed in a raised maze that has two arms that are enclosed in walls. And two arms that are just open platforms. So the rats are curious and want to explore, but they feel safer within the closed arms than exposed out on the open arms. So more time spent investigating these open arms indicates that the rat has less anxiety. So then the next test is a social interaction test, where they spend time with a novel peer and more time spent initiating contact and investigating the peer indicates less anxiety. And then finally, the light dark box test, which is kind of similar to the elevated plus maze, where they're placed in a two-chamber box, one that's completely enclosed and the other that is open. And basically they feel safer in the dark box but they still want to explore. So more time spent investigating the light side of the chamber will indicate less anxiety. So all three of these tests typically show sex differences in their behavior, where females tend to show less anxiety when exploring novel environments like the elevated plus maze and the light dark box, but they tend to show more social anxiety in the social interaction test when compared to males. So on to my results. First, I'm going to talk about the elevated plus maze. So I found the expected sex difference within my control groups, where females made more entries into the open arms and, while not significant, spent more time on the open arms when compared to control males, indicating that they had less anxiety. However, with LNG treatment, these females made less entries and spent less time on the open arms, indicating that their anxiety was increased with this treatment. With LNG treatment, there was no sex difference, where they kind of fall in the middle of this of the two control groups. So that's going to be a common theme throughout my results. But next we have the light dark box. So again, I found the expected sex difference between the control groups, where females took less time to emerge into the light box at the start of the test, and they spent more time overall investigating this light box when compared to control males. So this indicates that they had lower anxiety. But with LNG treatment, while there was no significant effect of treatment, you can see that this sex difference is now removed. And so the males and females treated with LNG are spending the same amount of time in the light box. And finally, I have the social interaction test results. So again, I found the expected sex difference in my control groups, where females spent less time interacting with a peer than the males did, indicating that they had increased anxiety on this test, which what we see in the literature is consistent with what we see in the literature. And then with LNG treatment, while there was no significant effect of treatment, it again removes this sex difference, where they're spending equal amounts of time with the peer with LNG treatment. And this is in between the two control groups. So just a quick overview of what I found. With the elevated plus maze, I found that control females showed less anxiety than males, and that LNG abolished this sex difference, and females with LNG treatment did show a significant increase in their anxiety. With the light dark box test, again, we found the expected sex difference where females showed less anxiety behavior. And this sex difference was abolished with LNG treatment. And so, based on just these two tests alone, some might conclude that LNG is having mild anxiety inducing effects. However, when we include this social interaction test, we see that females are more anxious in the control group. And this sex difference is again eliminated, which indicates that LNG is almost decreasing their anxiety. So this kind of led us to create this overall composite anxiety score, where a positive score indicates that the rodents are more anxious, and then a negative score indicates they're less anxious. So this is just Z-scores from all of the behavior tests. And you can see that there's no difference between any of the groups. They're all relatively normally distributed across the scale. However, taking into account this expected sex difference on the social interaction test compared to in the reverse direction compared to the other two tests, we created what we called a femininity score. So a positive score indicates that a more female typical behavior on these tasks, where a negative score indicates a more male typical behavior. And so you can see the control groups, the female controls have positive scores and because they're showing typical female behavior, and the same with the males where they have negative scores showing typical male behavior on these tasks. But with LNG treatment, both of them are brought to zero. So it's almost masculinizing the females' behavior with LNG treatment and then feminizing the males. And so this kind of my study seems to suggest that LNG is masculinizing female behavior. And this might be the result of LNG acting at androgen receptors, which is where testosterone tends to act in the body. And then LNG may be preventing maybe interfering with the hypothalamic pituitary gonadal axis, which is the system in your body that regulates your production of sex steroids. And so this example I have here with the elevated plus maze just shows that they found the sex difference in regular male and females. And then when they removed their gonads, this sex difference was eliminated. And so it seems that LNG is having a similar sort of interference with this system. Yeah, I just want to quickly thank my supervisor, Dr. McCormick, and the rest of the McCormick lab. And I will open up to questions.
Thanks so much, Alison. Some really interesting results there with LNG being administered in that kind of mid-adolescent period. Same idea, please feel free to post your questions in the chat or please raise your hand and I can call upon you to, yes, Francis Chen, please go ahead.
Hi, thank you. Alison, that was so interesting. So thank you for the presentation. I actually have two questions. Hopefully they're brief. The first one is, as someone like me who studies humans, can you give me a little bit of a translational take on this? Like, out of those three tasks that you use, should I be thinking of them kind of like generalized anxiety or like social anxiety or like something more specific like agoraphobia? So the first question is like the translational piece of what this means for like, human anxiety. And the second question is one about effect sizes. Again, because I'm not as familiar with animal research, non-human animal research, yeah, I don't know, like, can you tell me beyond the significance of the findings that you have, like the statistical significance, the practical significance, right? I think your measures were all in time, like latency to do something, right? Or yeah, amount of time doing something. But can you give me like a kind of scaling of like how big of an effect is that difference in the time that you're observing relative to other kinds of effects that you might see with other kinds of drug treatments with the rats, or other, like if you remove their gonads entirely, what would you see in terms of the change in the latencies on these particular tests? Thank you.
Yeah. So in terms of the translational, I guess, explanation, I would say closer to generalized anxiety as opposed to like a specific kind. All of these tests have been validated through use of medications that reduce anxiety in humans. And so, like if I were to give any of these rats some sort of medication that's known to reduce anxiety, it should reduce anxiety on these tests. So that's kind of how it's validated. So I'd say generalized anxiety more so than anything specific. And in terms of effect sizes, I mean, I would say that it's all of the variability within the sample is not super large. Like that's kind of a benefit, I guess, of preclinical research. So I would say any significant or like difference in the latency to do anything would be a fairly like big effect. I mean, I had effect sizes included on my graphs for my overall scores, and you can see that the Cohen's d was like 0.7, 0.8, which are relatively large effect sizes. I don't know if that answers your second question to an extent, but
Yes, thank you.
Okay, thank you so much. Great discussion. We do need to, for time's sake, move on to our next speaker, but thank you, Alison.
thanks.
And next up, we have Alice May.
Hi, yeah, I'm just going to share my screen really quickly. So can everybody see? Perfect. Awesome. Thank you for the introduction, Laura. My name is Alice. I am currently in my third year of my undergraduate degree in neuroscience at the University of British Columbia. And I'm also a research assistant in Dr. Gillian Hanley's lab, which is a UBC OV care lab, and we do a lot of prevention for ovarian cancer. I'm presenting a project today that I did last summer on contraceptive use in British Columbia, Canada, between 2001 and 2021 as a descriptive analysis. So before we begin, I would just like to give a quick land acknowledgement that I'm currently located in Vancouver, BC. And as a quick overview, I will be going through background and rationale, some materials and methods, findings, as well as my discussion and conclusions. So to start with the different types of contraceptive methods, there are currently a huge range of reversible contraception in Canada. And the two most common forms are the oral contraceptive and the intrauterine device. And the oral contraceptive is favored because of its ease of use and its high effectiveness when used correctly. And the intrauterine device, which I'll also be referring to as an IUD, is favored because of its low maintenance and its long-term efficacy. So an intrauterine device is also known as a long-acting reversible contraceptive, also known as a LARC. So one type of the IUD is the Levonorgestrel IUD, which is also called the LNG IUD, and it's a progestin-only form of long-term contraception that can be used for up to 5 years. It was first approved in Finland in 1990 and then introduced in Canada in 2001. So in terms of types of irreversible contraception that is currently offered in Canada, we have tubal ligation, which is the tying or clipping of the fallopian tubes, and we have bilateral salpingectomy, which would be the removal of both fallopian tubes. And so questions that we wanted to answer with this project, outcomes of contraceptive use that we would like to study are obviously pregnancy prevention and also the risk and non-risk for various types of cancer like ovarian, breast, endometrial, and colorectal. And so the study aims of this project were to firstly describe these changes in various rates of contraception and also discuss the possible effects of these changes on cancer and non-cancer outcomes. And so jumping into the materials and methods, we created annual cohorts using the following 5 data sets from British Columbia, and these annual cohorts from 2001 to 2021 included women who were aged 15 to 55 who were living in BC for more than 275 days of the year. And the exposure variables that we were looking for were the dispensation of an oral contraceptive, which could be combined or progestin only, the dispensation, which was also followed by the insertion of any IUD, and the insertion of another contraceptive device like the ring or patch, as well as hospital admission for any of those tubal sterilization procedures. So when we were measuring IUD use, the data was only able to capture the incidence, which would be the rate of dispensions and insertions per year. But then we also wanted to know how many people were actually using this contraceptive each year, given that after being inserted, it can be used for up to 5 years. And so we calculated prevalence by assuming that everyone who had had an IUD inserted in the past 5 years had continued using. So we would just sum up the insertions from the past year and the current year to kind of estimate that prevalence. We then ran a statistical analysis and calculated simple proportions, as well as a Mann-Kendall regression model with send slope to estimate kind of annual percent point changes of these contraceptive use, as well as the median age of users. And so jumping into our findings, this is our figure 1 of reversible contraceptive use in BC from 2001 to 2021. And we can see that top blue line is the combined oral contraceptive pill, which was the most common during this study period, but started declining in around 2010. LNG IUD prevalence and incidence are shown with the dark purple and light purple line respectively. And we can see that after its introduction in 2001, it started growing in popularity and almost got to around 10% of the study population. In terms of irreversible contraception, we can see that the red line shows that these forms of irreversible contraception are overall showing a decline, but it's made up of a bigger decline of tubal ligation and also an increase in bilateral self-injectomy rates. So these are our findings as annual percent point changes, and we can see that the biggest clinical changes are in the LNG IUD incidence and prevalence at 0.1 and 0.6 percent point changes per year, as well as the combined oral contraceptive that's decreasing by around 0.2 percent point changes per year. So then we decided to look into the median age of these users to see what kind of age groups are leaning towards which kinds of contraception. And we can see that IUD users, including the LNG IUD and the copper IUD, are generally decreasing, which indicates that younger age groups might be leaning more towards these forms. Oral contraceptive rate is remaining quite stable. So as a summary, our findings have shown that oral contraceptive use has decreased while the LNG IUD use is increasing, and tubal ligation rates are decreasing while bilateral self-injectomy rates are increasing, and the median age of copper and LNG IUD users are decreasing. And so let's talk about why we might be seeing those changes. Currently, LARCs are endorsed as primary contraception in Canada. So when young women are going into their doctor appointments and choosing contraceptions, they are recommended LARCs like the LNG IUD. And then when we're thinking about that decrease that we saw in combined oral contraceptive pills starting in around 2010, we're kind of thinking that because of a lot of poor media coverage around that time, we might start to see that decrease. And then in terms of the increase in bilateral self-injectomy rates in 2015, the Society of OBGYN recommended the opportunistic self-injectomy as a form of ovarian cancer prevention, which would explain that increase in rates. So then in terms of discussing the cancer and non-cancer outcomes of these changes, that shift from COC users to LNG IUD users have important effects on ovarian cancer and breast cancer risk. They both have the risk of endometrial cancer, so we might not see significant changes there. But the combined oral contraceptive decreases ovarian cancer risk by around 40%, while it's still rather unknown for the LNG IUD because it's so new. Another finding for breast cancer is that COC increases breast cancer risk by about 30%, and there is still no indication for the LNG IUD. And then in terms of irreversible contraception, bilateral self-injectomy and tubal ligation are both known to decrease ovarian cancer risk, but by very different amounts. So bilateral self-injectomy decreases by around 80%, and tubal ligation decreases the risk by 13%. So this shift from tubal ligation to bilateral salpingectomy is a great thing, although we are worried that with a consistent decrease of irreversible contraception, we might be losing this opportunity for ovarian cancer prevention. And so future directions of this work would be to investigate rates of contraceptive use following BC's free contraception policy that was implemented in April of 2023, and also continue to monitor contraceptive use patterns and associated cancer rates. These are just a quick page of my references, and I would like to thank my team and Dr. Jillian Hanley for this project, and I welcome any questions.
Thanks so much, Alice, for this really interesting data on trends in use over time. For any questions, please, again, post them in the chat or feel free to raise your hand. I'll give it a second. I'll keep my eye on the chat, but if I'm not seeing any questions pop up, maybe I'll ask a question if that's all right. I was wondering if you had any sense for potentially side effects or other reasons, perhaps indicating a switch in use of contraception methods. I'm not sure what kind of, it's amazing that you were able to combine data from so many data sets for your analysis. But yeah, I was wondering if you could maybe give some insight there to maybe any self-reported data or other data you might have that might give a window of insight into reasons for maybe switching kinds.
Yeah, unfortunately, because we're using those big population-based data, we don't really have access to any self-reported data on experienced side effects. But I think it would be very important to look into and get kind of that patient perspective on contraceptive use and why certain choices might be being made.
Yeah, very interesting. I think just seeing such a decline there with the combined oral contraceptives and seeing such a jump in IUDs, just wondering, I guess, out of curiosity, if anyone's like switching from the pill to the IUD and some of the motivations there. But yeah, really interesting trends.
Yeah, well, thank you.
Of course. I'm not seeing, and feel free, Emily Ann, to just call upon me if I'm missing any questions in the chat. I don't see any movement there. Maybe I'll ask one more question if that's okay.
Sure, yeah.
So this is interesting about kind of bilateral salpingectomy. I guess, rates. And maybe can you explain a bit more about like this 2015? I'm not sure if there was a particular act. I missed it in your talk, but maybe why that was instituted and how this might be contributing, I guess, to the rates in bilateral salpingectomy.
Yeah, for sure. A really important finding came out in the early 2010s that ovarian cancer or various forms of ovarian cancer can begin in the fallopian tubes. So this finding kind of led to the opportunistic salpingectomy, which is the bilateral removal of the fallopian tubes to hopefully prevent ovarian cancer. And so that's been something that's being implemented in BC and hopefully growing across the world and in Canada.
Yeah, really interesting there about the origin being the fallopian tube and then maybe jumping to the ovaries there. So thank you so much. I think for timing, we'll move on to our next talk, but thanks so much, Alice. For our next speaker, we have Holly MacDonald. So I'll pass it over to you.
Hi, everyone. I'll just start sharing my screen. Here we go. Wait, start. Okay, perfect. So, hi everyone. So today I'll be sharing the results and, well, the methods and results of the thesis I did while doing the Masters of Public Policy and Administration program at Carleton University. So, the research question of the thesis was, does Ontario's 2019 Health and Physical Education curriculum facilitate access to contraceptive for youth in grades 7 and 8? So just briefly, I'll go over my positionality, which informs the research process that I chose. So I identify as a woman. My experience as a woman impacts how I see myself as a researcher, my research goals, and how I define successful policies. I'm a graduate student in the Master of Public Policy and Administration program. So my experience in education legitimize analytical concepts used in academic critical feminist writings, such as the patriarchy, misogyny, and gender power dynamics. My education experience also shaped my critical feminist lens, which I use to analyze policies to understand how they impact the lives of people assigned female at birth or people who identify as women. Yeah, and it also impacts the approach that I took and the perspectives that are more reflected in the research process and findings. All right, so contributions. So hopefully this research contributes to further sex education research, such as defining youth sexual health needs, as well as the important role sex education plays in maintaining and enhancing youth's health and well-being, as well as the development of sex education curricula that is more effective in meeting youth sexual health needs. Furthermore, regarding public health, we know that timely access to effective contraception reduces the occurrence of unintended pregnancies, as well as the consistent and proper use of contraceptive methods, such as condoms and dental dams, protect individuals against sexually transmitted and blood-borne infections. Furthermore, we need access to contraception. Contraceptives are currently underutilized in Canada. More than one half of Canadian youth are sexually active by the age of 17, and more than 25% of youth report that they do not use contraception at every active sexual intercourse. Furthermore, social health inequities. So, sex education is one of the few opportunities available to youth to have conversations about their sexual health with an adult. Furthermore, regarding gender health inequities, this project adds to research on facilitating AFAB people and youth's access to contraceptives and the positive impacts access to contraception has on health. Not all unintended pregnancies are unwanted, and they can result in positive outcomes for parents and infants. However, research has found that unintended pregnancies resulting in adolescence can result in negative impacts on the physical, emotional, socioeconomic lives of youths, infants, and their families, lower educational achievement, income, and increased reliance on social welfare programs, as well as the risk of unsafe abortions. Aside from the prevention of unintended pregnancies and STBBIs, some hormonal contraceptives play a significant role in the healthcare of people assigned female at birth, such as regulating menstrual cycles, reducing menstrual pain, and used in lessening the symptoms of endometriosis and polycystic ovary syndrome. Therefore, it's really important to facilitate students access to resources which help them take care of their bodies and have more control over the futures now, and to have this information to carry with them throughout the rest of their lives. These are the three concepts which guided and informed the research process: risk-centered sex education framework, hidden curriculum, and access to contraception. So we'll go over them in a bit more detail. This project conducted research to help discover key characteristics of each of these framework and then apply it to the curriculum, as well as interviews with teachers. The key characteristics of a risk-centered sex education framework are the use of a practical and moral rationale. The moral to justify the delivery of sex education. A moral rationale refers to religious ideologies, whereas the practical rationale refers to secular reasons to justify sex education. Both of these rationales are not sex positive. As well as the emphasis on the prevention of physical harms, such as STBBIs, unintended pregnancies, as well as emotional harms, such as the negative emotions people experience when relationships end. These frameworks also promote abstinence and delaying sexual activity. Abstinence is often presented as the optimal method for youth to use to maintain their sexual health. These frameworks also reflect assumptions about youth sexuality and sexual health needs, assumptions like, childhood innocence, that youth are not and should not be sexually active, and that conversations about sex sexuality are disruptive to the natural innocence of youth. These frameworks also perpetuate sexual and contraceptive stigma because contraceptions are only talked about within the context of sexual activity, engaging in sexual activity. So conversations around contraceptives tend to be associated with almost promoting sexual activity. Also the concept of the hidden curriculum. So I conducted interviews with educators to determine their accounts of the hidden curriculum in their schools surrounding sex education. So the hidden curriculum refers to students' learning experience outside of the explicit contents in the curriculum. And this is how I analyze the curriculum and interviews with teachers to assess how this education facilitates students' access to contraceptives. I adapted Levesque and colleagues' access to patient-centered access to healthcare framework to show how sex education can support students in accessing contraception by increasing the demand dimensions of access to healthcare. And so the methods. So I used a critical discourse analysis on the Ontario's 2019 Health and Physical Education to understand how the risk-centered framework is operationalized within the curriculum. And then I conducted interviews with teachers to determine if the risk-centered framework is reinforced through their implementation of it, as well as, their interactions with students and the school board. And I conducted a critical discourse analysis on the interview transcript data to determine that. So the findings indicate that there are gaps in Ontario's 2019 Health and Physical Education curriculum that impede the curriculum's capacity to facilitate access to contraception for youth in grades 7 and 8. There are also variation in teachers' accounts of the hidden curriculum surrounding access to contraception in school. Yes, so the risk-centered frameworks prioritize controlling youth sexual behavior, and they also reinforce assumptions about youth, which oppose facilitating youth access to contraception, such as we can see here below. So the gaps in the risk-centered framework to facilitate students' access to contraception indicates that it is up to teachers to facilitate students' access to contraception, whether or not they are able to fill these gaps. Some teachers' accounts of the hidden curriculum reinforced the risk-centered framework, which means they perpetuated assumptions about youth and limited information, which would increase their ability to access contraception, whereas other teachers did not reinforce the risk-centered curriculum in their account of the hidden curriculum by delivering sex education through a sex-positive perspective and kind of going beyond and including more information than what's in the curriculum to support students in accessing contraception. This means that, the variance in teachers' accounts of the hidden curriculum and the gaps in the curriculum's risk-centered framework on facilitating access to contraception perpetuates inequities in education, gender, and healthcare. And here's just sort of a little figure looking at the language that's used in the curriculum. So we can see here that they use multiple different types of language to kind of get the same meaning across. And it's a little bit uneven, but they use language such as protection the most instead of using like specific terms, which sort of, gatekeeps information. But yeah, that's everything I have for today. Thank you so much for listening.
Thank you so much, Holly, and really interesting insight from interviews with the teachers there. Again, just wanted to open it up for questions. Please feel free to post your question in the chat and I'll read it aloud, or raise your hand and you can unmute. Maybe I'll also jump on this. I have so many questions for everybody, but Holly, if you don't mind me asking a question, I thought it was great how you introduced your positionality at the beginning of your talk. And I was just wondering about the kind of positionality of the teachers that were interviewed. And maybe if you could comment on perhaps the gender of some of the teachers and how that might have influenced findings, or any other insights there, maybe how the background of these teachers might have influenced perhaps some of what you saw coming through in your results there.
Oh yeah, that's a really awesome question and like a really important part of the hidden curriculum. So I interviewed 6 teachers. 2 of them were male, 2 of them were newer to the profession, whereas 2 of them were approaching retirement. And 2 of them worked in the Catholic school board because in Ontario we have public Catholic school boards, and the rest worked in the public sort of secular school board. And I found school board was the biggest thing that influenced how teachers were approaching this, how they were comfortable doing that. So that was the biggest part. But it was interesting. Also, gender played a role in it as well. What information teachers felt was important to share was influenced by gender, I found. And yeah, it was really interesting. One of the interesting findings was that regardless of everything, all teachers kind of were stuck with the conflict of, what is the appropriate timeline as opposed to seeing healthcare as the central to sex education.
Sorry, I had trouble unmuting there. Thank you so much. Yeah, I really appreciate that kind of like deep window. And I haven't started qualitative research yet, but I think there's so much rich data that comes from those interviews. So thank you for giving that insight. For now, we're going to move to our next speaker, but thank you, Holly. I would like to hand it over to Melanie Kowalczyk.
Thank you. Hello, everyone. I'm going to share my screen. Okay, can you see everything?
Yes, that looks good.
Okay, so I'm a PhD student at SWPS University in Warsaw, in Poland. And this is one of the studies that I conducted during my PhD project with Dr. Kornacka and Dr. Kreitz. And the study is on anxiety and depression in women who cycle naturally and in women who take all contraceptives. So I would like to start by saying that women are twice as likely as men to suffer from anxiety and depression, and the symptoms of these disorders tend to get worse in the luteal phase, especially a few days before menstruation. We also know that a lot of women take oral contraceptives. However, the link between oral contraceptive use and anxiety is pretty understudied, and the literature, there's no consensus in the literature on this topic. So we have studies that show that taking oral contraceptives make anxiety worse or better, or there's no difference. So this is something that we really need to study further. However, we know that when women start taking oral contraceptives in adolescence, they have a higher risk of developing depression in adulthood. So these are 2 topics that we thought were very interesting to look at. And we know that using oral contraceptive is linked with a decrease in hormones, so estradiol, progesterone, and a very big decrease in testosterone. We had participants who were using combined oral contraceptives with ethylene, estradiol, and progestins. And progestins can be androgenic or anti-androgenic. So androgenic progestins are derived from testosterone, but anti-androgenic progestin block androgen receptors, and there's a higher decrease in testosterone in women who take anti-androgenic oral contraceptives. And these oral contraceptives are often used not only for contraception, but also, for instance, to treat acne. So the goal of our study was to check the differences between daily anxiety levels and daily depression levels between women who cycle naturally and women who take oral contraceptives by taking into account these two types of progestins. And we also added some protective and negative factors that are related to anxiety and depression. And those factors are perceived stress, perseverative cognition, so it was rumination and worry, and self-esteem. So we had 89 women in our study. We had 49 women who were cycling naturally, and we needed women who had regular menstrual cycles. So usually regular menstrual cycles are defined as between 21 and 35 days with less than 7 days of difference. But we needed women who had at least 28 days because of our methodology, which I will describe in a moment. So we had 31 women without contraceptives and 48 women who were taking all contraceptives. And in that, we had 32 with anti-androgenic and 16 with androgenic. And from what I've understood, I believe that in Europe, doctors tend to prescribe anti-androgenic or contraceptives more. And in North America, I think androgenic, but I'm not sure about this. So maybe someone can tell me about that after my presentation. So the women who didn't have oral contraceptives were given an individual menstrual cycle calendar, and this was calculated based on the date of their last menstruation onset and the usual length of their menstrual cycle. And this calendar was divided into 3 phases. So we had the menstrual phase, the follicular phase, and the luteal phase. And even though all contraceptive users don't have those phases and they don't have hormonal fluctuations like this, we gave them the same kind of menstrual cycle calendar because we wanted to see the parallel between the cycle in women who are cycling naturally or taking oral contraceptives. So the oral contraceptive user usually had 28, 29 days, and they were given calendars that were the equivalent of women cycling naturally who had 28, 29 days cycles. So what we did was that we gathered data for 5 days in each of the phases. So that was 15 days in total. And they were receiving an email in the evening where they had to reply to questions. And those questions were 3 items that were taken from existing threat level scales and that we adapted for daily administration. So for instance, there were questions like, how often today did you feel stressed and things like this. So what we found was that there was no difference in daily levels of anxiety, worry, perseverative cognition, and perceived stress. However, the oral contraceptive users, both groups of oral contraceptive users, had higher levels of daily depression and lower levels of daily self-esteem than naturally cycling women. And this rather lack of link between oral contraceptive use and anxiety is something that we've been seeing in my entire PhD project. So we never found any link between oral contraceptive use and anxiety. However, when we did research on bigger samples, we found that oral contraceptive use was linked with higher levels of worry and lower levels of inhibitory control. And these are variables that are linked to a risk of developing anxiety. So we think that we should be doing more research into this. And however, we found these higher levels of depression. And since we know that women who start taking oral contraceptives in adolescence already had this higher risk of developing depression in adulthood, this is another topic that should be studied further. So the limitations of our study were obviously the observational design. We didn't ask the participants whether they had actually a diagnosis of anxiety or depression. Oh, I didn't write it here, but we also didn't ask them whether they were taking oral contraceptives for contraception or other reasons. And we didn't take any hormonal measurements. So what we would recommend for further studies would be larger samples, more intensive repeated measures, so daily diaries, but also ecological momentary assessments. So this is when you send questions to the cell phones of your participants randomly throughout the day, and they can reply and say how they are feeling at that moment. And since we know that conducting randomized control trials in contraceptive studies is difficult, we agree with Dr. Bells, who said that we could test women before and after they start taking all contraceptives, and then they could be followed over a long time after they start the treatment to see how their well-being evolves. So intensive repeated measures and longitudinal studies. And if you would like to dive deeper into our studies, into our study and into the references, I invite you to read our article that was just published in BMC Psychology. And I would like to thank you for your attention, and I would really like to answer questions if you have any.
Thanks so much, Melanie, for that really interesting data on some of the mental health links with oral contraception use. Again, please, if you have any questions, feel free to post them in the chat or raise your hand. Yes, please, Francis.
Sorry, I don't mean to hog the Q&A part. I was waiting to see if anybody else had a question, but thank you, Melanie. That was really interesting. I was curious, and sorry if I missed this if you actually said this already in the talk, but do you have data on former use of the hormonal contraceptives, oral contraceptives among your sample?
Do you mean how long they've been taking it, or if they took other contraceptives before?
Right, or correct. So even, for example, the ones that are currently naturally cycling,
Not taking.
you have a history, yeah, not taking.
No, we didn't ask them, and this is all the things that we think we should be asking in further studies because it's missing. So no, we didn't ask this.
Okay, thank you.
Maybe one follow-up question I have as well related to those who are taking the pill. Did you ask whether, I know some individuals will skip that kind of placebo pill or inactive week. Did you know in your data set if they were currently taking, I guess, on the active forms of the pill at the time that they were filling out those questionnaires?
Yes, it should have been only during the active phase of the oral contraceptive.
Okay, interesting. And do you know of any literature that maybe has compared like active versus inactive? I'm not sure if there's any
Yes,
literature
there
on
is
that. Yeah.
literature on this, and I believe, well, I'm not 100% sure because there have been a few, but I think there was no difference between active and inactive phase.
Great. Thank you so much.
Thank you.
Okay. I think, thank you again so much, Melanie, for your talk. And I think we'll move on to our next and final speaker for today, which is Jessie Lacache.
Okay, let me just get my slides fired up here. Thank you, Laura. Okay, is everybody able to see my slides? Get one thumbs up.
I don't see your slides, Jessie.
Oh, okay, hold on one sec. How's this?
Yes, that looks great.
Okay, perfect. It's not presenter view, right?
No, I
Okay.
just see your slides.
Let's roll. Well, thank you so much, everyone, for sticking around to watch my talk today. I'm going to be presenting research from my postdoc, which is co-supervised by Dr. Lisa Galea at CAMH and Dr. Cheryl McCormick at Brock University, where Alison is doing her research right now. So let's just jump right into it then. So, as we've already heard a couple times today from a couple of my co-presenters, there is this association with hormonal contraceptive use and depression. And in this kind of landmark 2016 JAMA paper that was published by Scotland et al., they showed this figure here, which showed the increased first use of antidepressants among contraceptive users. And what they showed was that in the youngest age cohort that they analyzed, the adolescent cohort, you saw the greatest rate or the greatest risk ratio of use of antidepressants. And so this link between the risk of antidepressant use or depression risk among adolescents who are using hormonal contraceptives has now been repeated multiple times throughout a whole bunch of different kind of epidemiological or data bank-based studies that have been published here on the bottom left. Over the last 5 to 10 years. So the question really becomes, well, why are adolescents seemingly a little bit more vulnerable to this risk of depression that could be associated with hormonal contraceptive use? And so we really wanted to dig into that. So one thing that you can look at in order to address this question is biomarkers of depression. So you could look at a variety of different physiological, biological markers that are indicative or that you see in patients with depression. And so some examples of these would be, for example, a dysregulation of the hypothalamic pituitary axis. What you see often with patients with depression is a blunting of their stress response, so they don't get a rise in cortisol in the face of an acute stressor. Another thing that you could see is the dysregulation of the functional connectivity networks in the brain. So another hallmark of depression would be that you see this dysregulation of the functional connectivity, particularly so with hypoactivation of the prefrontal cortex and hyperactivation of the amygdala. But that's just one thing that you see. You see other stuff as well, but that one will be noteworthy for later. And then another thing you could look at are dysregulation in the neuroinflammatory system. So in some cases, you see increases in pro-inflammatory cytokines in patients with depression. In other cases, you see reductions in some of the anti-inflammatory cytokines. So these are all just kind of physiological markers that are associated with depression. So we used a preclinical animal model here where we looked at adolescent female rats and adult female rats, and we injected them with the combination of ethinyl estradiol and levonorgestrel, and the combination, which represents a formulation that's used popularly in North America. It's the most used combination for combined oral contraceptives. We treated the rats with this combination of drugs for 16 days, and on the 16th day, we restrained them for 30 minutes. And rats don't like that. They get a stress response, and this is to evaluate how they are responding to stress, both at the endocrine level, but also at the neural level, which we will see. Okay, so here's what we did. We took a blood sample at the baseline, and then we put them into their restraint for 30 minutes, immediately took another blood sample, and then 90 minutes later, we took a blood sample to see how their corticosterone level, which is the rat equivalent of cortisol, the stress hormone, was responding to this stressor. And so what we observed in the adult cohort was, if you look at the dotted line here, this is our vehicle treated group, meaning they did not get contraceptives. And you see they have this totally normal stress response where you get this elevation in corticosterone in response to the stressor. And then 90 minutes later, it returns back down to baseline. And with the adult cohort of animals who were treated with contraceptives, you could see that they also had a stress response, but it was an attenuated release of corticosterone. And so you actually get less. You get about 70 to 80% of the release of corticosterone, which is typical. At least 2 other studies have demonstrated this same kind of general trend in adult rodents administered EE and LNG in combination. Okay, so that is different than what we saw from the adolescent cohort. So in the adolescents, if you look at the dotted line, you see the vehicles, those not treated with hormonal contraceptives, they get a pretty typical stress response. But those who are treated with contraceptives, you see this kind of flat-ish line. You get this blunting of the stress response. So this is really our first indication here that adolescents are showing a greater sensitivity to the kind of stress-related effects of hormonal contraceptives. And so this is kind of our first biomarker that is really showing an increased vulnerability among the adolescents. So Check there. Now we move on to the brain, and what we could do is extract their brain and take a look at all of these different sub-brain regions that are related to processing stress and that are also related to depression in humans. And you can stain them with something called CFOS. And CFOS is something that's going to indicate that a neuron was recently activated, usually within the last 90 minutes. And what you can do is then quantify how many cells are coming back as positive, and that looks like these little red dots here, these really dense red dots. That will come and indicate a CFOS positive cell, and then you can quantify how many cells were positive within each of these brain regions of interest. And you can start building up this idea of the activity within certain brain regions at the time that the rats were being stressed. Okay, so then you take all of the activity in each individual region and you correlate it to the activity in other regions to see how these regions correlate in terms of their activation with each other during stress. Okay, so then in collaboration with another postdoc in the lab, Andrew McGovern, he ran this network analysis where you can effectively look at the correlations between the different regions and then present them in such a way that you can actually represent how the activation patterns between these brain regions relate to each other. And so you can easily see here that different brain regions are either highly connected or clustered together. And what's really obvious here is that the functional connectivity networks and the patterns here of results are very clearly different depending on age and on treatment. So I'm not going to get into all of the different ways that you could look at this type of data, but one particular way that you could look and quantify this is looking at eigenvector centrality values. So the eigenvector centrality value considers the connectivity between brain regions, but it doesn't only look at that. It looks not only at how many connections one particular brain region has, but how connected are the areas that it's connected to are as well. So let me give you an example just so we can be a little more clear on this. The yellow node here, it is clearly receiving connections from many of the different brain regions coming from all around, either directly or indirectly. But not only is it receiving a lot of connections, the brain regions that it's connected to are also highly connected. So you can see that they're orange or yellow, which indicates a greater eigenvector value. So this yellow node here is highly connected. Lots of brain regions to communicate with each other have to go through this yellow region, and therefore it is a highly influential brain region. Now contrast that with this purple node out here. It's not very well connected. It has about 2 connections here, and even those connections are not very well connected to the overall network. They're still kind of peripheral to the network. And so they don't really carry a lot of influence as it comes to the overall weight of that brain region within the network itself. Okay, so you take the eigenvector values, you plot them out for each brain region that you were interested in, and then you can plot out that brain region across all of the different treatment groups that you had. And so I'm going to focus in, because there's a lot of data here, on some of the more interesting results that came of this. So first, let's focus in on the amygdala. In red here, we've got the adult rats that were treated with hormonal contraceptives, and in green are the adolescents treated with hormonal contraceptives. What you see is that the amygdala in rats treated with hormonal contraceptives is a highly influential region within those rats' networks. And so you see that the amygdala is really playing this greater role during restraint stress in rats who were treated with contraceptives. And it's interesting because the amygdala is this classic area that's related to stress processing and anxiety and stuff like that. And so very interesting that you're seeing kind of this greater influence of the amygdala in rats treated with hormonal contraceptives. Now let's look at the prefrontal cortex, because this is where it gets interesting as it relates to the adolescents. Now the adolescents treated with hormonal contraceptives are the little green bar here. So what you see is that in adolescent rats treated with hormonal contraceptives, you actually get less influence of the prefrontal cortex within the network. It becomes less influential with the treatment of hormonal contraceptives during restraint stress. And so something about the developing adolescent prefrontal cortex being exposed to these exogenous hormones is reducing its influence on how the prefrontal cortex plays a role in the processing of stress. Okay. So now we know that the prefrontal cortex and the amygdala are important regions in how hormonal contraceptives are impacting the adolescent brain and the brain of HC-treated animals in general. And so what we looked at next was another biomarker, like I pointed out earlier, which are some immune markers or some inflammatory markers in the brain. And what we observed was that rats treated with hormonal contraceptives actually had reduced levels of interleukin 4 in both the prefrontal cortex and in the amygdala. And this is across both age groups. So adults and adolescents just had this global reduction in interleukin 4, which is an anti-inflammatory cytokine. So it's not necessarily that we found all of this increased pro-inflammation, but we did show this reduction in anti-inflammation in the brain regions that seem to be the most important on the functional connectivity stuff. And then another signature of the adolescent brain, though, was in only the prefrontal cortex, which, if you recall from the functional connectivity data, also seemed to be the only spot that showed this adolescent-specific signature. What we saw was this reduction in interleukin 10, another anti-inflammatory cytokine. So in only the adolescent cohort and only in their prefrontal cortex did we see that they had this big reduction in the interleukin 10 anti-inflammatory cytokine. And again, only in the adolescents, which is why it's interesting. So to summarize kind of the different biomarkers that we've looked at and how they change depending on age, this is only with treatment with HC. What we saw was an attenuated corticosteroid response, and that this effect was much larger in the adolescent cohort. We saw that there was increased amygdala connectivity in both cohorts treated with hormonal contraceptives, but that there was a reduction in the influence of the prefrontal cortex only in the adolescents treated with HC. In both cohorts, we saw that HC reduced the levels of interleukin 4 in the brain, in the prefrontal cortex and in the amygdala, but only in the adolescents did we see this decrease in the other anti-inflammatory cytokine, which is interleukin 10. So this really is starting to point and kind of triangulate these age-specific signatures of biomarkers that are changing in relation to HC administration during stress, and really showing an age-specific vulnerability of the adolescents when it comes to the prefrontal cortex. So it's really just given us a lot more to chew on. And so with that, I will thank my mentors for this project, Dr. Cheryl McCormick and Dr. Lisa Galea, everybody that helped me collect this data, and other members of the Galea and McCormick lab, and of course the rats that were used in this study. So thank you very much.
Thanks so much, Jesse. Really exciting to see such comprehensive biomarker data on adolescent hormonal contraception use. Again, please, we have time for one question, so please either post in the chat or raise your hand. Jesse, there is one question in the chat for you. Oh, I know Matea also has her hand up as well. I will read out the chat question, and then Matea, if your question's quick, maybe we can also cover that. As our understanding of contraceptive mechanisms deepens, do you see momentums towards renaming or reframing these drugs by mechanism rather than by their outcome? For example, contraception.
Yeah, I think it's a good question. I think there's definitely some space for that. I mean, at the end of the day, they are really used for the primary purpose of contraception, but it doesn't mean that they can't be used as tools in other conditions. And I think that that's something that we already do quite a lot of. And so, sure, it could totally be worthwhile to maybe not rename, but reframe the idea of what these drugs are used for, depending on their mechanism of action. And so I think you bring up a totally fair point.
Thank you for that question. Matea, we can quickly do your question, so please feel free to unmute and ask.
Sure. Yes, you can hear me?
Yeah.
Really cool data, Jesse. If you were able to quickly pull up the interleukin 4 slide, I just have a very specific question.
Is my screen still being shared?
No.
Okay, here, how's this?
Yes.
It's up now.
How's this?
Yeah, this one. So I don't know if this is just me because I don't usually work with rodent data, but for the prefrontal cortex, it almost looks like for the hormonal contraceptives, there's like two subgroups in terms, so some of them don't show reduce interleukin-4, but then there's a bunch at the bottom that end up dragging down the average over like the ADO piece. But actually, yeah, for both the prefrontal cortex and the amygdala, but I was mainly looking at the prefrontal cortex. Do you have any thoughts on why there might be like two clusters, perhaps, of hormonal contraceptive treated?
So I don't have any particular thoughts about it because this is fairly new data, but it's definitely something that we've seen while looking at the data. And obviously, some rats seem to be more vulnerable than others to the effects we're observing. And so, those four rats there at the bottom might end up being the key to understanding something like this. And so, we know who they are, we know what their results were on the functional connectivity and stuff like that. And so hopefully, although I don't have any insight into why they fell down there versus the rest of the group, it's interesting to think about of that group, what made some of them more resilient to the effect, while others clearly were the ones pulling the effect that we observed here. And so I think that's more to be continued, but definitely something that we're thinking about is why are some of them more vulnerable? And that's really what you'd expect in a normal population anyway. And so, not everybody taking these contraceptives is getting depressed or anxiety or something like that. It's going to be a certain vulnerable subset. So actually understanding who these rats are, what happened to them that might be unique, that could be the answer to figuring out really what we're after here.
Yeah, definitely cool individual differences. Thanks.
Yeah, thanks, Matea.
Thank you so much. Such interesting questions and discussion. We're just going to wrap up here with two concluding slides, and then we'll send everybody off. First off, we just wanted to make an announcement that a survey has launched. This is by the Hormonal Contraceptive Working Group to really explore how hormonal contraceptive use in Canada affects health and well-being. Just we recognize that there's not a lot of deep, comprehensive surveys that really explore the everyday experiences of people who use contraception. So please scan our QR code and take our survey. We would love to have you be a part of our data set. We can move to the next slide, please. And I'll hand this over to Emily Ann, who explain how to become a Women's Health Research Cluster member.
Absolutely. Yeah. Thanks so much, Laura. So just wanted to put a quick post in here to let folks know that you are all welcome to become members of the Women's Health Research Cluster. Membership is open to everyone. It is free, and it's a really great way to get involved with a leading organization and sort of see what comes out and get access to exclusive student awards and all other kinds of benefits. So you can follow the QR code here on the screen, or we'll also be sharing a link to do that in our follow-up email. Thanks so much, everybody.
Wonderful. And with that, I just want to thank all of our wonderful speakers today who did such an excellent job in really sharing their work and furthering progress on this really understudied area of women's health. So thank you so much to our presenters again, and thank you all for joining today. Take care. Okay, I think we'll get started. Hi, everyone. Thank you so much for joining us today for our trainee research presentation, Hormonal Contraceptive Insights from Across the Field. My name is Laura Growlsons, and I'm subbing in for Lisa Galea today. And I'd like to just start off with a land acknowledgement. We recognize that we live, work, play, and participate in community on the unceded, ceded, and traditional territories of the 630 First Nations. each of which possess their own unique traditions and history here on this land that we now refer to as Canada. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action and the United Nations Declaration on the Rights of Indigenous Peoples. In all of our work, we are committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I am joining you from Toronto, which is covered by the Toronto Purchase Treaty Number 13 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. Many of our members live in Vancouver, which is part of the unceded homelands of the Coast Salish peoples and the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. Thank you so much for joining us, everyone. Today, we're here to talk about hormonal contraception, which are often treated as routine, everyday medicine, but they shape some of the most intimate parts of people's lives. Decisions about birth control can affect health, identity, relationships, autonomy, and well-being over time. Even though so many people rely on these medications, we still have big gaps in our understanding. We're still learning how they affect the brain and mood. We are still learning why some people have positive experiences and others do not. And we're still trying to understand how access is shaped by systems like education, healthcare, and policy. And we're still working to make sure that people have real options based on informed choice, not just availability or circumstance. This is why research and conversations like this matter. They help us move from assumptions to evidence, from stigma to clarity, and from one size fits all to care that actually reflects real experiences. So thank you to our wonderful trainees for contributing to this important progress. And thank you to you all for being part of this conversation today. Just a few housekeeping notes. We will be having 10 minutes for each presentation. And right after that presentation, we'll have 5 minutes for questions. I think we're probably ready to get started. So for our first speaker, we have Tendo Babirye.
Okay, I'm going to share my screen. Can you see my screen? Yep.
Yes, that works great.
Okay, perfect. Thank you. So good afternoon, everyone. My name is Tendo Babirye, and I will be presenting my research findings from a scoping review that examines how incarcerated women within Canadian correctional facilities experience access to hormonal contraception. So the outline highlights the key sections we will cover. So this includes the background, a little bit more about the research, key identified barriers, and proposed interventions. So just to give you a little bit more background, so hormonal contraceptives contain estrogen and progestin and are widely regarded as safe for pregnancy prevention. They also come in various forms such as oral pills, patches, vaginal rings, and intrauterine devices. Beyond contraceptive efficacy, hormonal contraception can support the management of endometriosis, PCOS, and heavy menstrual bleeding. Given the wide range of benefits, it is crucial that contraceptive users are adequately supported to choose a method aligning with their preferences, their needs, and their reproductive health goals. However, this can be difficult to achieve within a correctional setting. So while women represent a rapidly growing population within Canadian provincial and federal correctional facilities, with most being of a reproductive age, access to reproductive health services such as contraception remains inconsistent and deprioritized. The United Nations Mandela Rules and Bangkok Rules outline standards for the treatment of incarcerated individuals and emphasizes gender-specific health care, including reproductive care for women. Although drug formularies may indicate that hormonal contraceptives are available, limited quantitative data and inconsistent documentation suggest that availability doesn't necessarily signify access within the correctional environment. So through a search of databases, particularly PubMed, 7 publications of which were published between 2016 and 2025 and conducted within Canada met inclusion criteria, and thus were included in the scoping review. So given this topic is generally under-researched, the scoping review aimed to synthesize available literature to better understand incarcerated women's experiences with hormonal contraception and identify barriers to accessing it, which could potentially inform interventions that can improve its access. So the review identified 5 main barriers to contraceptive access in these settings, which included structural and institutional barriers, mistrust in correctional reproductive health care, competing health needs, limited reproductive health knowledge, and challenges with continuity of care. Each barrier is further broken down into subthemes, which are shown in the figures 1 to 5 in the following slides, along with supporting quotations from women with lived experience in Canadian correctional facilities. So structural and institutional barriers had a strong influence on incarcerated women's access to hormonal contraception. Quantitative data supports the quotations presented in Figure 1, where one study found that among the 14 women who reported the use of hormonal contraception prior to entering custody, only 5 women had continued while incarcerated. Thus, within a correctional framework, institutional challenges may compromise and limit reproductive autonomy, influencing access to contraception. This is evident in requests for reproductive care and admission processes, where research found that when submitting a health request to correctional officers, many women experience gatekeeping of services, violations of confidentiality, prolonged delays in processing requests, or the overall denial of care. So these procedural gaps actually reflect a broader absence of policy affirming access to hormonal contraception and the protection of incarcerated women's reproductive rights. One study found that none of the 14 jurisdictions contacted had maintained an up-to-date policy supporting access to hormonal contraception. This could explain the limited count of contraceptives provided by the jurisdictions. Thus, while both federal and provincial laws recognize inmates' rights to accessing health services, an absence in proactive contraceptive policy highlights potential barriers to its access. So another barrier identified would be mistrust in correctional reproductive health care, reflected in concerns about mistreatment, breaches in confidentiality, coercion, and discriminatory practices. A number of incarcerated women reported feeling judged or dismissed when requesting health care, particularly by correctional officers. As a result, asking for family planning services, such as hormonal contraception, can create significant discomfort in this population. So the mistrust also extended to healthcare professionals. So many participants described having experienced reproductive coercion, where contraception use was either completely imposed on them or denied because of the institutional restrictions on sexual activity. So the correctional environment thus deepens mistrust and reinforces inaccessibility to hormonal contraception. A key barrier would be competing health needs, as incarcerated women often have complex health histories of which intersect with their reproductive health outcomes. In these studies, the women emphasize the significance of having their socioeconomic and general health needs met prior to being prepared to plan for or prevent pregnancy. So thus, while numerous women experiencing incarceration described having to prioritize specific needs over others, this is due to the scarcity of resources and limited access to healthcare services in correctional settings. Given this, reproductive health care, including access to contraception, is often overlooked to prioritize